Hello, so we will discuss about tachyarrhythmia in this section. Now, cardiac arrhythmia, what exactly they do? Cardiac arrhythmia affects the cardiac output. We all know that cardiac output is stroke volume into heart rate, and cardiac arrhythmia can affect both heart rate and the stroke volume. So, cardiac output is decreased, and because of the decrease in the cardiac output, all the manifestation and the clinical features of arrhythmia would be seen in the patients, right? But the presentation of arrhythmia can vary from innocuous ECG changes to cardiac arrest, and the management differs on the basis of presentation. So we have to know that at what presentation, what approach in the management we have to take. So as I said, cardiac arrhythmia, what does it do? Cardiac arrhythmia affects cardiac output, right? Cardiac output is equal to stroke volume into heart rate, and arrhythmia is affecting both heart rate and stroke volume. This leads to decrease in cardiac output, and all the manifestation of arrhythmia is because of this decrease in cardiac output. So whatever is the type of arrhythmia, whether it is brady or the tachyarrhythmia, right, which we will discuss about, the overall effect of any arrhythmia is decrease in cardiac output. And because of the decrease in cardiac output, whatever clinical presentation is seen, the same clinical presentation would be seen with any type of arrhythmia, whether it is brady or tachyarrhythmia, right? Clinical presentation of poor perfusion because of decreased cardiac output. Poor perfusion mostly to the vital organs, brain and heart. So manifestation of shock or hemodynamic imbalance, acute chest discomfort, or acute heart failure, other manifestation, cardiac manifestation, then neurological manifestations like your syncope, etc. may be seen in the patient, right? So let us discuss how the arrhythmias can present. I said it can present as an innocuous ECG changes to the cardiac arrest, the extreme two ends of the presentation. And definitely the management depends upon its presentation. So let us talk about its clinical presentation of arrhythmia. So it varies from asymptomatic findings in ECG to symptoms without hemodynamic instability. Symptoms without hemodynamic instability. Hemodynamic instability, right? Then it can present with hemodynamic instability, but the patient is conscious and has a pulse. So hemodynamic instability in conscious patient, or it can present as cardiac arrest. So definitely, if it is presenting as cardiac arrest, what we need to do is cardiopulmonary cerebral resuscitation, right? If it is asymptomatic finding in ECG, number of times we need not treat it, we just need to monitor the patient. But if it is presenting with symptoms, what is our approach? Well, it depends upon the symptoms which it is producing, and it depends upon the type of arrhythmia the patient has. So, right, our management would depend on that. But initial approach for any kind of cardiac arrhythmia with symptoms is same. So, what is the initial treatment? Whenever a patient comes in arrhythmia, what should be our approach? So, initial treatment is same, initial approach is same, and the initial approach is what is your primary approach. So, we know the primary approach, that is the ABC approach. So, we see the airway of the patient, we see the breathing of the patient, we see the circulation of the patient. And if the time permits, if the hemodynamic imbalance is not quickly happening, too much hemodynamic imbalance, we secure an IV cannula as soon as possible, and we get a 12 lead ECG done to see what is the type of arrhythmia the patient is having, because management would depend on that, right? So always for any arrhythmia, this is the initial approach. A, B, C, IV line secured and 12-lead ECG done. Okay. Now let us divide the arrhythmia into two types, tachy and bradyarrhythmia. So we will talk about the arrhythmia. It is divided into tachyarrhythmia, and bradyarrhythmia, right? We know the heart rate is, the normal heart rate is between 60 to 100 beats per minute. And if the heart rate is above 100 beats per minute, then it comes under tachyarrhythmia. If it is below 60 beats per minute, it comes under bradycardia and bradyarrhythmia. Okay. So whenever we get a patient with tachyarrhythmia, what are the things that we have to see? First, we will discuss tachyarrhythmia, then I will discuss with you bradyarrhythmia in the next section. So how do we define tachyarrhythmia? Now, three important things is what we have to see in the ECG of the patient for managing tachyarrhythmia. Number one, heart rate, which should be above 100 beats per minute, as I have already discussed. Then we need to see the width of QRS complex. So we know the normal width of QRS complex is between 0.9 to 1, right? 0.9 to 0.09 to 0.1, right? This is the normal width, 0.09 to 0.1 seconds, okay? Now, if the width is more than 0.12 seconds, right, then we call it broad QRS complex. It should be between 0.09 to 0.1. If it is above 0.12 seconds, we call it broad QRS complex, right? Then we need to see whether the PR interval is regular or not. So PR interval is the third thing we have to see. On basis of these three, the tachyarrhythmia would be divided into different types of tachyarrhythmia, and the management would depend upon the type of tachyarrhythmia the patient is having. Okay. So how is tachyarrhythmia divided? We have to see the heart rate. The heart rate is above 100 beats per minute. So definitely it is tachy. Then the next thing we have to see is the QRS complex. Whether the QRS complex is narrow or wide. If it is more than 0.12 second, it is wide QRS complex. If it is less than 0.12 seconds, it is narrow. More than 0.12 seconds, it is wide. So let's say it is a narrow QRS complex. The next thing we have to see is PR interval. That is, the QRS complex is coming at a regular interval or irregular interval. We have to see the PR interval, and also we'll see the morphology of QRS complex. Okay. If it is regular, the PR interval is regular, the heart rate is regular, the rhythm is regular, then what could be the differential diagnosis? The sinus tachycardia is the first differential diagnosis. How we diagnose it, I will talk about it. Whatever is the cause of sinus tachycardia. Then AV nodal reentrant tachycardia, which comes under PSVT, paroxysmal supraventricular tachycardia. Then AV reentrant tachycardia. Then focal atrial tachycardia, atrial flutter, junctional tachycardia, sinoatrial nodal reentrant tachycardia, right? And very rarely ventricular tachycardia can also present as narrow QRS complex. But let us forget it. This is a very uncommon manifestation. So if I see the regular one, how do I divide the narrow QRS complex with regular PR interval, right? Tachyarrhythmia. What are the different tachyarrhythmia comes under it? Number one, sinus tachycardia, right? Sinus tachycardia. Number two, any nodal reentrant tachycardia. The atrioventricular nodal reentrant tachycardia, or atrioventricular accessory path tachycardia, or let's say sinoatrial nodal reentrant tachycardia, right? So any of these reentrant tachycardia, AV nodal reentrant tachycardia, which is the most common, AVNRT, AV nodal reentrant tachycardia, then AV reentrant tachycardia, then sinoatrial reentrant tachycardia, right? Sinoatrial nodal reentrant tachycardia, right? And atrial flutter, right? So management of these three would be same. Sinus tachycardia management approach would be different, and atrial flutter, the management approach will be different, right? So narrow QRS complex with regular PR interval. If the narrow QRS complex has irregular PR interval, right? Irregular PR interval, then what could be the differential diagnosis? The first and the most important in this is your atrial fibrillation, then multifocal atrial tachycardia, then focal atrial tachycardia with variable AV block, and atrial flutter with variable AV block, right? So in with irregular PR interval, the narrow QRS complex tachyarrhythmia, the differential diagnosis is the most important atrial fibrillation, then your atrial flutter with variable nodal block, atrial flutter with variable block, right? So this would present as irregular PR interval tachyarrhythmia, okay? So these are narrow QRS complex tachyarrhythmia. If the QRS complex is wide, right? And then again we have to see whether the PR interval is regular or irregular. What is the morphology of QRS complex? So for regular QRS complex, the differential diagnosis, the most important is monomorphic ventricular tachyarrhythmia, right? And sometimes the supraventricular tachyarrhythmia also presents as wide QRS if the aberrant conduction is present, right? With aberrant conduction. So supraventricular tachyarrhythmia with aberrant conduction. But remember that management of supraventricular tachyarrhythmia and ventricular tachyarrhythmia is entirely different. In supraventricular tachyarrhythmia, the management is basically on AV blocking, which should not be done in ventricular tachyarrhythmia. So if we are not clear by that what is the cause of tachyarrhythmia, the wide QRS complex tachyarrhythmia, by default, it should always be diagnosed as ventricular monomorphic tachyarrhythmia, right? Irregular ventricular tachyarrhythmia, it could be the polymorphic ventricular tachyarrhythmia that we have to keep in mind. Ventricular fibrillation, which would result in cardiac arrest, because fibrillation is not the rhythm compatible with life. So these two is what we are going to consider. So for wide QRS complex, for wide QRS, right? Wide QRS complex tachyarrhythmia, we need to see two things. What is the morphology of QRS? If it is regular, QRS is regular, then it is monomorphic, right? And if QRS is irregular, then it is polymorphic. So these two is what we would focus on, okay? So as I would revise for you that supraventricular tachycardia we have discussed is mostly having narrow QRS complex. So as I said, the tachyarrhythmia is divided into your, depending upon the QRS complex, the narrow and the wide. And the narrow QRS complex tachyarrhythmia is mostly of supraventricular origin. So we will first talk about supraventricular tachyarrhythmias, which is also called narrow QRS complex tachyarrhythmia, right? Complex tachyarrhythmia, right? Tachycardia or arrhythmia, okay? Now, whenever we have supraventricular tachyarrhythmia, what are the things we see? As we see, we have to see the PR interval. The QRS is narrow. We have to see the PR interval. We have to see the PR interval is regular or PR interval is irregular, right? Then we have to see the presence of P wave, presence or absence of P waves, right? P wave is present or not. So just a small flow chart that whenever a patient with tachyarrhythmia comes to us, first we do the initial evaluation in which we see that this patient is having any manifestation of tachyarrhythmia, any clinical feature of tachyarrhythmia, in any serious sign and symptom of tachyarrhythmia. So what could be the serious sign and symptom of tachyarrhythmia? So what could be the sign and symptoms? As I said, the sign and symptoms would be present because of decrease in cardiac output. So most of the manifestation would be because of poor perfusion. So what we will see that there could be a possibility of signs of shock due to poor perfusion, then acute chest discomfort. Patient will complain of acute chest discomfort because of poor perfusion to heart. Then features of acute heart failure. Then patient may have syncope because of poor perfusion to brain, right? So these would be the clinical sign and symptom of decreased cardiac output. So we have to see whether the patient is having these clinical sign and symptoms or not, right? So if patient is stable, as I said, we secure an IV line and we get a 12 lead ECG done. And then we see whether the rhythm is regular or irregular. If the rhythm is irregular, right? If the rhythm is irregular, then we need to see whether the P wave is present or absent. So if P wave is absent, it is atrial fibrillation. If instead of P wave, it is replaced by flutter wave, it is atrial flutter. And we have multiple P wave morphology, then it is multifocal atrial tachycardia. If the rhythm is regular, right, then P wave and P waves are, we have to see P waves are detectable or not. If P wave is detectable, mostly it is sinus tachycardia due to any cause. We will talk about it. And if the P wave is not detectable, then it is mostly paroxysmal supraventricular tachycardia, that is any re-entrant tachycardia, any re-entrant supraventricular tachycardia, right? So this is how we have to do the initial evaluation and we have to see what kind of tachycardia the patient has. Now, during initial evaluation, if the patient is having sign and symptoms which is making the patient unstable, so patient is having all these signs and symptoms of tachyarrhythmia, then in that case, irrespective of the type of arrhythmia, we would not even wait for 12 lead ECG to be done if patient is going into hemodynamic imbalance. If the patient is unstable, immediately, irrespective of type of tachyarrhythmia, we need to go for the cardioversion. So on initial evaluation, if patient is having the serious sign and symptoms due to tachycardia, that is hypotension, shortness of breath, chest pain, shock, decreased level of consciousness, patient is unstable, right? Once the patient is unstable, we quickly attempt to determine the rhythm is sinus or it is non-sinus rhythm. Mostly unstable, there is a possibility it could be sinus rhythm, but mostly it is not sinus rhythm. If it is not sinus rhythm, immediately we have to do cardioversion. And if there is no time to detect it, think it that it is not sinus rhythm and we have to go for cardioversion. If it is sinus rhythm and we have little time, then we try to treat the underlying cause which is causing this sinus tachycardia. It could be myocardial ischemia, it could be the IV beta blocker, maybe that dose inappropriate dose, right? So let's say that if the rhythm is sinus rhythm, then definitely we will have some time, we'll try to treat the cause. Okay. Now, if this rhythm is not sinus and unstable, we straight away go for cardioversion. So if tachyarrhythmia is unstable tachyarrhythmia, in that case, immediate cardioversion is what we do, right? Cardioversion is different from defibrillation. In defibrillation, we give the shock immediately as soon as our pad of the defibrillator touches the chest of the patient. But in cardioversion, when we press the shock button, the shock is not immediately delivered. It is delivered synchronized with the ECG waveform of the patient. It is delivered at the peak of the QRS complex. So it is not delivered at the refractory period of the heart, so that the risk of conversion into ventricular fibrillation is decreased. So cardioversion is what we do, right? Okay. So if on initial evaluation patient is stable, then the management depends upon the type of tachyarrhythmia. So one by one, we will discuss the different types of tachyarrhythmia and what would be their, let's say, management. Okay, when the patient is stable and giving us time for the management. If the patient is unstable, immediately we have to do the cardioversion. Now, let us start our discussion with different types of tachyarrhythmia, starting with sinus tachycardia. Okay, sinus tachycardia. When do we say it's a sinus tachycardia? Well, sinus tachycardia, that is sinus node. The origin is from sinus node, and on ECG, the P wave is present. And it is always followed by QRS complex. Then what is the only abnormality in sinus tachycardia? The only abnormality is heart rate, which is more than 100. Normally, it is between 100 to 150. Now, mostly the sinus tachycardia is a physiological response to different clinical condition. So, it is mostly the physiological response, right, to number of clinical conditions, like if the patient is having pain, if the patient is having fever, or if patient is anxious, if patient is in shock, or let's say if patient is having myocardial ischemia, which is a, let's say, a condition, a serious condition which is manifesting as sinus tachycardia, we have to recognize it. So it's a physiological response. If you will remove the physiological response, the patient can get deteriorated. So sinus tachycardia as per se is not treated. Rather, the cause which is producing the sinus tachycardia should be treated. We should know that mean heart rate is age dependent, and anyone's maximum heart rate which can go is 220 minus age. So this is the maximum heart rate how we calculate. So for let's say 20 years old adult, it is 220 minus 20. So his normal maximum heart rate can go up to 20 beats per minute, and it would be under sinus tachycardia, right? So remember, it's a physiological response. It should not be treated. We should not give the drugs to decrease the heart rate. We should rather treat the condition which is causing it. So it should be directed, the treatment should be directed in remedifying the cause. So treatment of sinus tachycardia is directed at remedifying the cause. Direct treatment of tachycardia can be deleterious in the patient, right? So it should be directed in remedifying the cause. Okay. So next tachyarrhythmia which I will discuss is your atrial fibrillation, right? So what is atrial fibrillation? It's a chaotic rhythm. Atrial fibrillation is a chaotic rhythm within atria. So apart from SA node, some ectopic atrial impulse generation site is created, and from that ectopic impulse generating site, chaotically the impulse is being generated at the rate of 350 to 600 beats per minute, right? So there would be, let's say, the SA node is not generating the impulse. Some ectopic foci in the atria is generating at the rate 350 to 600 per minute. P wave will not be seen. P wave not appreciated in ECG, right? And all atrial beats, impulse would not get, let's say, would not go to the ventricle because of the AV nodal delay time. So all atria beats are not conducted because of refractory period of AV node, because of refractory period of AV node, right? So that's because of this we get a irregular rhythm, right? Now, if the ventricle rate is less than 100, atrial fibrillation can be asymptomatic. But if the ventricular rate is high, more than 100, then cardiac output can get compromised and clinical manifestation may be there. Now, how would atrial fibrillation would be seen on ECG? So definitely the heart rate, that is, it would depend upon the ventricle response rate. So it could be less than 100, it could be more than 100. What about the P waves? Are we able to see the P waves? No. P wave, there is no P wave. P waves absent, right? Or we call it fibrillating waves rather than P wave. So P wave is absent, we get fibrillating waves of the atria. Then QRS complex is narrow, QRS is narrow, and PR interval, I mean there is no P wave, so it's difficult to say PR interval, so rather I should not write it. RR interval is irregular. So rhythm would be irregular, the rate would depend upon the ventricular response rate, and P wave would not be seen. So this is how we will diagnose atrial fibrillation. Absent P wave, it is replaced by fibrillating wave, narrow QRS complex, RR interval is irregular, and the heart rate depends upon the ventricle response rate, and clinical manifestation also depends upon the ventricle response rate. So as I said that the clinical feature, it could be asymptomatic, and if heart rate is more than 100 beats per minute, then there could be possibility of cardiac output getting decreased. And because the heart rate atria is fibrillating, the contribution of atria into the cardiac output is very much diminished. So blood stasis in the atria happens. So formation of thrombus, etc. can happen because of the stasis of blood in the atria. So loss of atrial contribution in cardiac output can result in stasis of blood in atria. This can cause intracardiac thrombus, right? So what are the causes of atrial fibrillation? Management, I would tell you, together with flutter. But what are the causes? It could be caused due to multiple reasons. So if I start writing the causes, the first cause, chronic cardiopulmonary disease. It can be a manifestation of chronic cardiopulmonary disease. So chronic cardiopulmonary disease, right? It could be the manifestation of thyrotoxicosis. It could be the manifestation of any infection or sepsis. It could be the manifestation of acute alcohol intoxication. Right? Stress can also lead to atrial fibrillation in older patient. Then pericarditis, right? Or pulmonary embolism. It is commonly seen without any reason in elderly and in post-operative patient, and it can be manifestation of acute myocardial ischemia also, right? So it can be because of multiple causes, right? Management, we need to find the cause if the patient is hemodynamically stable rather than and if the ventricular response rate is very high, we have to control the ventricular response rate. So we will discuss about the management. Okay, so we have to control the rate, and we may require to convert the rhythm into sinus rhythm if the patient is in atrial fibrillation. And number of times, if there is no symptoms, we may just monitor the patient on the regular basis and do not treat the condition. We just try to treat the underlying cause of the condition. So this is atrial fibrillation. Now let us talk about atrial flutter. Fibrillation was because of chaotic rhythm generated by atria from some ectopic foci. Flutter is because of reentrant of the rhythm, reentrant rhythm located in the atria. So flutter is caused by reentrant rhythm localized in mostly right atria, localized in right